This is Charles. I'm one of the surgeons at Southpaws. Today we have an interesting case, which is a healer or Kelpie cross that has a nasal carcinoma in the right nasal cavity extending all the way up to the frontal sinus. So we did a CT scan and a biopsy a couple of weeks ago, confirmed the presence of this tumor, and so now we're doing a dorsal rhinotomy, and that'll be followed up with radiation therapy in a couple of weeks. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone the next time we live stream. So again, this is a 6-year-old Kelpie that has a history of a right-sided bloody nasal discharge. And so about 2 weeks ago we did a CT scan which confirmed bony lysis. And bony lysis is, well, it's not absolutely pathognomonic for nasal carcinoma. It is very suggestive. And so we did a biopsy, and Kelpies, please. And that confirmed the presence of a nasal carcinoma. So our treatment options with this case are either a surgery combined with radiation therapy here at Southpaws. We only have orthovoltage radiation therapy here, so it's not the best radiation therapy that you can get. To get that, you'd have to go up to Sydney or Brisbane. And so the owners have decided to have us do surgery, and the combination of surgery at our practice with radiation therapy at our practice is associated with a median survival time of about 2 years, which is as good as anything else that's published, possibly with the exception of a linear accelerator combined with surgery. I can see here that we've already got a little bit of perforation through the nasal bone right there, so I'm already getting a bit of mucus there. So I'll just get a Kelpie, and then I'll get a periosteal elevator. So treatment options with nasal carcinoma include surgery and radiation therapy using orthovoltage, surgery and radiation therapy using a linear accelerator. You could try just chemotherapy, and that has some benefit in some patients, but certainly not in all patients. You could also do just piroxicam, and that has some effect in some patients, but again, not in all patients. So I'm just using coblation here to clean the bone off. You can see that it's just vaporizing all that soft tissue and leaving the bone basically devoid of any blood supply. Coblation is an interesting modality that creates a plasma gas field at the tip of the electrode that just vaporizes any organic tissue. So people use it most commonly in ear, nose, and throat surgery. And actually one of my friends, who's an ENT, was the first one that introduced me to the idea of using coblation in my ENT patients. And so I use it a lot for brachycephalic dogs for staphylectomy. I've done a few laryngeal sacral excisions with it as well and found it to be quite effective. The benefit of coblation over electric cautery or ligature is that ligature and electric cautery both raise the temperature of the surrounding tissue to about 450 degrees Celsius. That's in contrast to coblation that only raises the temperature up to about 50 degrees Celsius. It's associated in humans, particularly with tonsillectomies, with a significantly reduced postoperative swelling, need for postoperative pain relief, as well as duration of hospitalization. So there aren't a lot of studies which have published its use in animals, I've used it pretty extensively in ear, nose, and throat surgery, as well as some tumor resections, and even in brain surgery. All right, so I've got some pitting of the bone here. I can see where we've got some tumor that's penetrating, or I assume it's tumor. And penetration of bone is very characteristic of tumor, and you really shouldn't see that with fungal infections or bacterial infections or anything like that. Nice thing about coblation is that there's also just regular bipolar electric artery at the tip of it as well. And basically, it cannot penetrate bone, but it can take out any soft tissue. So it's nice because you can basically clean right down to bone. I won't need that anymore, Soph. So you can clean basically, yeah, right down to bone. I won't need that. Can I get the burr, please? Do we have can we get a 5 mil burr, please? So I'm just going to use the burr to thin the bone a little bit. And the prognosis, if we do a combination of surgery and radiation therapy, is a median survival time in our patients of about 26 months. Paige, if you want to scroll up and see if there are any questions that we missed. No. Is that all of them?
Just
okay.
a lot of the people saying.
All right, so I'm just going to use this burr. Let's get some saline. So this is over the frontal sinus here. And often in these cases, it's hard to tell whether there's involvement of the frontal sinus or if it's just nasal discharge. I'm just thinning the bone a little bit so it'll just be a little bit easier to chip away with the rongeurs. Basically, these guys will bleed extensively from the minute you penetrate the nasal cavity until you get all of the tumor out. So I'm trying to reduce that time period as much as possible. Often I'll start in the frontal sinus because the frontal sinus usually doesn't bleed very much. So we'll often get some stuff like that. So there's some nice little goopies. Soph is suctioning out the discharge. Now I'll get my kerosene rongeur, see if I can pop into the frontal sinus here. So most of that in there is mucus. And again, the frontal sinus bleeds less than the nasal cavity, so I usually try to get in there first. If you haven't had lunch yet, you might want to wait till after this surgery. Our suction is pretty average today. It's very variable. Do we have a Yankauer suction tip? I won't need it yet, but I just want to make sure we have it. So there is tumor in the nasal cavity, I can see that. So this is all secondary to the tumor because there's obstruction of the nasal passage. They all develop this kind of brown mucus in there. And that's often what you get as a nasal discharge. Just trying to get all of that mucus out. So that's all tumor in the frontal sinus in there. Yep.
Is the tumor unilateral or bilateral?
The tumor is unilateral. Now, often they are bilateral, but in this case, it's unilateral in that. I think it reduces the, obviously the blood loss, it reduces the amount of side effect that we're going to get with the radiation therapy when you make the field smaller. Side effect that you get in the skin is related to, in part, the surface area of the treatment portal. So I just now need to remove enough of the nasal bone that I can get my yank our suction tip in. Oh, the other thing I'll need is a Carmalt forcet. And we will not replace this bone. So one of the risks or complications that we see with this procedure is subcutaneous emphysema, and can be a bit distressing to the owners. It doesn't cause any discomfort to the patient unless it gets really bad. And I'm going to extend my rhinotomy all the way basically to the rostral end. And I'm trying to stay superficial so I don't really get a lot of bleeding until I'm ready to manage it.
There's another question.
Yep.
They're asking, are you going to do electrochemotherapy?
So I'm not doing electrochemo, I am doing coblation, and then we're going to follow up with radiation in a couple of weeks. Almost to the rostral end of the tumor. It's looking more like normal turbinate there. So now, this is when, did we get a Carmalt?
Oh, sorry. The other example. You've got a few questions.
Yep.
So one of them is unrelated to the procedure. Do you want to answer?
Yeah, that's fine.
Yeah. So it says, do you have any experience performing sodium chloride injections into inoperable intramuscular lipomas?
Intramuscular lipomas. Is that what it says, lipoma?
Yeah.
I would think that there's little to no evidence to support it. I know that people have tried it with mast cell tumors as well, and the literature is Yeah, there's just nothing out there that suggests that it's going to provide any survival benefit. We'll send some of this off for histopath just to confirm our diagnosis, although there's no question about it. So now this is just going to bleed extensively until I can get it down basically to white glistening bone.
Someone asks, what is the recovery like for these patients? Is quality of life good after a rhinotomy?
So quality of life with these guys, the first week or so is not great. It's not terrible. It's not the worst surgery we do, but they're not terribly comfortable. After that, they're pretty good. Radiation therapy, the quality of life is good for the first 3 weeks and then gets a little bit worse when they start getting some side effects. Side effects last a few months, and then they're usually back to a good quality of life again. Can I please get a large curette, like the biggest one you can find? Yeah.
How many of these have you done? This is my first time seeing such a procedure.
So I've done about 50 of these, something like that. We submitted for publication, I think 28. We're up to about 40 with the combination of radiation therapy and rhinotomy. And we haven't had anybody come back and tell us they wish they hadn't done it. So the success rate is pretty good. Yeah, that's great. Thank you.
Another says, hello from Romania. Thanks to your videos. Had the courage to do this surgery 2 months ago. Lots of bleeding, but with 5 minutes compression with a sponge and suction, managed to finish the job.
That's great. And so just remember that this surgery by itself, without radiation therapy, really doesn't provide any survival benefit in the literature. So you have to make sure that you're going to follow that up with either radiation or with maybe metronomic chemotherapy, something like that. There's a nice big chunk of tumor there. Can we get the bulb syringe, please? Yeah, that's good. It's cleared itself. I was going to get the bulb syringe to try to clear the suction, but it's cleared itself.
Someone says, how long do you keep them hospitalized after surgery?
So usually just 24 hours. I like to send my patients home as soon as I can. Once we're under control of pain or have pain relief under control, I'm happy to send them home. So I think patients recover better at home than they do in hospital. Now I'm just going to pack the nasal cavity and start working on the frontal sinus. And then once we get that bleeding under control, I'll come back with the coblation and just try to effectively sterilize it, or as much as I can, get back down to bleeding bone. So there's tumor there in the frontal sinus. And again, often it's just just nasal discharge in the frontal sinus, but this one has proper tumor invasion, and that was evident on the CT scan. We could actually see contrast-enhancing material. And this surgery is obviously not for the timid.
Someone asks, is there a nerve block you can do for this area?
There is not a nerve block that you can do for this area that I'm aware of. So we just do a lot of systemic pain relief. Let's get some flush.
Another says, I believe you said you biopsied this before surgery. Was that a surgical biopsy or via rhinoscopy?
It was via rhinoscopy. So we did a rhinoscopic biopsy after the CT scan.
And what are your pain control meds of choice?
Have I moved my camera? No. So we'll use either, so we'll use some kind of full agonist opiate, and either, so that'll be either a fentanyl CRI or methadone, and then we usually, or sometimes can add ketamine and lignocaine as well, and we can add things like gabapentin, paracetamol, that sort of thing. All right, so the nasal cavity is pretty good. I'll just pack that off a bit more. I'll start coblating the frontal sinus, because there was definitely tumor up there when we started. And coblation can also help me with hemostasis a little bit. It's not great at hemostasis, but it's better than nothing. So I don't know if you guys can see this, how it's turning the bone just completely white up there. Can I get about a 20 ml syringe, please? There's a question about whether coblation kills tumor cells. I mean, it just vaporizes all organic tissue, so I can't help but think that it does, although I've never read any study or anything that confirms or refutes that. Let's go ahead and fill that up with saline. I'm just flushing the coblation through. Can I get my blade, please? If you want to go ahead and flush that a little bit and just hold on to that handpiece there. Otherwise, we're all going to get soaked. Should have been in 3D. All right, Sophie, that's enough. Okay. So so we'll connect that back up to the suction. Okay, let's switch back over to the normal suction. Grab me a Yanka, or a Fraser. Thank you. So now I'm just little by little, this may need to be unplugged. I can try it with a syringe. That's good. So little by little, I'll remove the cotton, the lap sponge, and then just coagulate as I go. We'll switch.
You've got 2 questions when you're ready.
Yep. Blaze.
So the first is a rhinotomy indicated for any other condition other than a tumour?
Sometimes we'll rhinotomy for a foreign body that you can't get out through a scope. We'll do that. The other thing is that for some fungal infections that are refractory to medical management, we'll do a rhinotomy, clean out as much as we can, and then we will treat with a local clotrimazole or something like that. Let's see if that's... let's just flush this out. So the lumen on the coablation unit is not very big. Can I get you to... We'll aim this at Alex.
Sorry.
Saying we'll aim the water at Alex.
You know what? Home gets to experience this aspect of it.
Okay, that's great.
How do you give the local antifungal?
So you just inject it. It's like a gel,
Okay.
and you inject it in. So the question is, how do we administer the antifungal medication? And the answer is that we just inject it into the rhinotomy and let it soak there for about 20 minutes. I might just use this as my suction. There's definitely tumor coming into right in this area here into the frontal sinus, so that's an area that I'm particularly going to focus on. Just saw a squirter there. Can you get a Ranger, please? Ruskin. Limpet's fine. And the more tumor I can get out during the surgery, the less work the radiation has to do, the more likely it is to be successful. Now, can I get another lap sponge, please? I'm just going to pack it into the frontal sinus, and then I'll move down into the nasal cavity. Okay, so the bleeding has stopped for the most part. Often we get some pesky bleeding that's up almost in the nasopharynx.
Was the CT reflective of how extensive the tumor is?
What's that?
Was the CT reflective of how extensive this tumor is?
Yeah, so the CT scan showed us pretty clearly what we were going to find in surgery. There's a question in-house about whether the CT scan is reflective of the extent of the tumor, and it is actually very accurately reflective of that. And I think that the success rate that we've had with the combination of radiation therapy and surgery for this guy reflects the amount of time that I spend really making sure that the whole nasal cavity is completely empty. Now what I'm going to do is I'm going to switch sides with my interns, and so that I can get a better look at the lateral aspect. And I might have to get the foot switch over here. Sometimes I'll get to this point and think I'm done, and then I'll pull out like an index finger sized piece of tumor.
I've got 2 questions,
Yep, go ahead.
I'm not familiar with this one. Does coagulation kill tumor cells?
Yeah, so question about whether coagulation kills the tumor cells. I'm pretty sure it does, although there's no literature that I'm aware of, but it's basically vaporizing all organic tissue. So I can't help but think that that it would be effective. Where's my foot switch? There it is.
bone and contents from an ossified frontal sinus?
I can't say that I've seen that before, but if you had cancer in there, I would. I'm not sure if it was a non-cancerous process. I'm not sure. It would depend on the case as to whether that's something that I would do or not. I'm going to switch over to my Fraser. Is our Fraser unblocked?
Oh, it's
Here it
right
is,
there.
yeah.
Could you use bone wax in this area if needed?
You can use bone wax, but because this is actually capillary, this is actually soft tissue that's bleeding, it's not particularly effective. Gel foam sometimes can be effective in these guys. And this one, honestly, has hardly bled at all, in comparison to some of these where you're actually really worried about hemorrhage. This one's pretty light. Carmalt. Just got some more soft tissue up here. And just to reiterate, with cancer, with nasal carcinoma, there's no place for surgery unless you're going to follow up with some kind of treatment. It doesn't provide any survival benefit. All right, I'm pretty happy with that. So now we'll just pull this out, make sure that we've adjust the majority of the bleeding. So I've got virtually no soft tissue left in the nasal cavity at all. So this is right up against the cribriform plate. A little bit of soft tissue left in here. So this is all, basically olfactory lobe or extensions of the olfactory lobe. A big goober of blood clot here. Yep. Yep.
Do you not replace the bones so that the radiation can penetrate deeper?
Good question. Do we not replace the bone so that the radiation can penetrate deeper? And the answer to that is no, because our radiation machine actually penetrates bone pretty nicely. We just don't replace it because there's nothing we can replace it with. I mean, you could try to take it out in one piece, but I have found that to be pretty ineffective. So we just don't replace it just because we don't have anything to replace it conveniently or easily with. And I wouldn't want to put something like polymethyl methacrylate or something, because that would just act as a foreign body and potentially get infected. So I'm just coming in and just making sure that I'm getting rid of all the soft tissue here. Can I get a Lempert Runger, which is the single action? Thank you.
Is there anything like empty nose syndrome in dogs like there is in people?
What's the syndrome called?
Empty nose.
I'm not familiar with that. We certainly do see some evidence of continued serous nasal discharge in these guys. Just because there's no absorptive surface in the nasal cavity to absorb any fluid that's being produced. I've almost penetrated over to the other side in one spot, but will irradiate part of the other. Can I get the foot switch, please? Yeah. So I'll go about 1 centimeter into the other nasal cavity. Let me get a DeBakey, please. So I'm just being really meticulous about getting as much soft tissue out of here as I can. It's a little bit of a dull part of the surgery. For really small tumors, there was a question about electrochemotherapy. For really small tumors, there are some that I've done just coablation and electrochemo, but with one as invasive as this, you definitely would have to follow up with radiation. So I'm really getting down to just white bone here, which is what I like to see. If the person who mentioned the empty nose syndrome is still watching, can you tell me where you heard about that? If you're a human medical professional? Curette, please. So there's still a bunch of soft tissue here. DeBakey, please. Thank you. And a Carmel, please. key again with these is to be super meticulous about making sure that we're getting all the soft tissue out. All right, I'm pretty happy with that. So let's just flush a little bit. We want to make absolutely sure that our cuff is inflated when we're doing this. Otherwise, it can aspirate a bunch of blood. Can I get some gel foam, please? A little bone bleeder here. Tear off about a 2 by 2 centimeter piece, please. You can just tear it off.
I'm not sure.
So this is gelatin hemostatic foam. It doesn't cause coagulation, but it supports it. Just push that in with my finger.
That person's written a comment explaining.
Okay, what is that? So what's empty nose syndrome?
So empty nose syndrome is a complication of nasal surgery, particularly
PDS.
turbinate surgery,
Yep.
Symptoms are like paradoxical nasal obstruction, persistent feeling of dyspnea, feelings of drowning and dryness.
Right. I'm not familiar with that, but I certainly believe that that would be a possibility. All right, so now I'm just going to close a sub-Q layer. And then I'll have one of the guys who scrubbed in with me finish the rest. And so post-operatively, we're going to be doing quite a bit of pain relief and just monitor for the development of sub-Q emphysema. Usually there's nothing you have to do about it, but occasionally we'll put a needle in through the skin and drain it.
In what cases do you leave a blowhole?
a blowhole just for fungal,
Okay.
in case you wanted to go back in and give more antifungal medication. I have heard of some people leaving a little hole and packing it with gauze if you have bleeding that's not easy to control. And you leave that gauze in for a couple of days and then just pull it out through the blowhole.
How long do you maintain the blowhole?
It'll close as soon as you pull out the sponge. Now, if it wasn't going into the frontal sinus, you can do a transpalatine approach to the nasal cavity, which is a little bit nicer cosmetically. So there's no incision on the top, but I have had cases where that's broken down and you're left basically with a huge oronasal fistula or cleft palate. So my tendency is to go in dorsally with these guys in most cases, unless there's really a specific reason to go in ventrally.
Do you ever do like a periosteal flap to promote bone healing?
On these,
Yeah.
I have never done that. So the question is if I ever would do a periosteal flap. That's not something that I have have felt a need to do. And when I'm finished with this, I'll go over and make sure there aren't any questions or comments that I haven't answered. I'll leave Sophie to close this intradermal layer. Yep. Thank you very much. All right, so I'll just come over and check the monitor to make sure that there are no questions that I haven't answered or comments. Hi from Germany. It's interesting about empty nose syndrome. Hi, California. Hi, Piyush. Hi, Florida. Hi, California. All right, well, that's pretty much it. So I'm going to go ahead and end the live stream, but thank you very much for watching. If you haven't already done so, please subscribe to our channel. Make sure you turn on notifications so you'll get a ding on your phone.